Well, thank you very much for the introduction. Thank you very much for the invitation to be here in this very appreciated for me Congress of the Mediterranean Society. Well, as you know, the title of this presentation of these instructional courses is related with personalized medicine, and specifically about gene therapy for hearing losses. Thanks to my team that is behind all this work, we are in front to a disruptive advance in medicine. So disruptive advance means ability to break with established rules or the way to doing things. So we are in front of a change. This is a very important moment because especially when we are speaking about etiologic diagnosis of the neurosensorial hearing losses, in most of the cases we don't have the etiological diagnosis. And now we are in the possibility to achieve this etiological diagnosis because most of the hearing losses, especially in children, are related with gene mutations. So this opened a new era. We, until now, work with audiometric and vestibular tests, but now we implement the genetic diagnosis and give the opportunity to have etiological diagnosis that gives the opportunity to personalize the treatment of these patients. The future of medicine lies in personalization. Personalized therapies for each patient allow for treatments applies more precisely and promptly, and therefore with better results. Traditional medicine tends to adopt the one-for-all approach. However, the goal of the personalized medicine is to apply an individualized treatment based on genetic traits of a patient. 60% more or less of genetic losses are genetic, caused by the alteration of one or few genes. And the genetic diagnosis of hearing loss opened the door to personalized treatments using hearing devices and even curative treatment based on gene therapy. Gene therapy can act on a cell genome and modify genes that determine a disease. Also, we can use this etiological diagnosis from a genetic point of view in the prevention and the prescription of hearing devices. For example, the mutation of GJB2 gene, which tends to cause severe to profound hearing loss, allows us to predict an optimal outcome with the early use of a cochlear implant. So this is very important in terms to counseling the families to tell them that the prognosis of the cochlear implantation in cases like that is going to be very successful. The detection of a mutation in OTOF, the gene that codes for otoferlin protein, causes hearing loss clinically framed within auditory neuropathies. And you know that in these kind of cases, it's also very important if you are going to treat these patients with cochlear implants to counsel families to say, in that cases, the prognosis of a cochlear implantation is very good, and now is a new opportunity not only to counsel about the use of cochlear implants, also to use gene therapy. But it's possible to prevent ototoxicity by detecting mutation of the mitochondrial MTHFR1 gene in people who are going to be treated with aminoglyceride antibiotics such gentamines, and streptomycin. Well, we are going to analyze the gene therapy in this spectrum of personalized medicine. What is the definition of gene therapy? It's a technique that modifies a person's genes to treat or cure disease. Gene therapies can work by several mechanisms, replacing a disease-causing gene with a healthy copy of the gene, inactivating the disease-causing gene that is not functioning properly, and introducing a new or modified gene into the body to help treat a disease. Today, we are in the moment to speak about gene therapy because we have some pillars that help to apply clinically this gene therapy. The first pillar is the early genetic diagnosis, the possibility to know this diagnosis of gene cause from the early stages of the life. If we add the hearing screening programs to genetic screening programs, you have the possibility to know about 3 months of age of this newborn that the cause of this hearing loss is due to a genetic disease. So this information that came from etiological diagnosis of the genes is very, very important, is one of the pillars. And technologically, we have important advances in that more and more cover a rate of positive results when we use these tools. The second pillar is the cochlear surgery. So we learn a lot about how to be atraumatic during the cochlear implant surgery, and all these concepts helps in the treatment of these child with gene mutation when we deliver into the inner ear the treatment. The third pillar is the knowledge about pharmacokinetics of the inner ear. Pharmacokinetics is very useful to know what are the mechanisms of the liberation of a determinate substance, what is the absorption of this substance in the inner ear, what is the distribution, the metabolism, and the elimination of this structure. All this knowledge are very important during the perfusion of a gene into the inner ear to know, well, volumes, times of delivering, etc., and etc. And the fourth pillar are the viral vectors. So we need a carrier that brings the opportunity to the gene to achieve the nucleus of the cells that are going to be treated with gene therapy. So all these pillars that we have today, due to the force of previous trials and laws, to talk about today of gene therapy. Well, we are working specifically with the treatment of children with mutation of the gene OTOF. And also it's very important when we are speaking to treat these children to do in early stages. Happen the same that happened with cochlear implants. Everybody knows today that it's very important, the correlation between the moment where we stimulate the auditory system and the results that we are going to obtain. So we note also that there is a limited period of time for gene therapy of the OTOF gene due to the progressive deterioration of the hair cells of the cochlea. So it's important, again, to talk about the concept of early genetic diagnosis when we are going to treat gene mutations. The first publication related with the results of gene therapy in autot mutation came from a group in China that shows results in 6 patients. You have here 3 figures. The first one is related with results of ABR. This is with ACR results, and this is pure tone audiometry. And you can observe how is the evolution over time from baseline results to the 26 weeks of follow-up. And you can observe in this first patient, this is the first patient, second, third, 4, 5, 6 patients, you can see how the results are improving over time, and at the end arrive to a level of speech of hearing detection around 20 to 30 decibels in the range of conversional frequencies between 250 hertz to 4,000 hertz. Most of them, from these 6 patients, all of them has good results, except this one, that they have some detection of sounds, but, you know, at the level of 80 to 100 decibels. So this was the first experience published, but we are working in another group, in another multicentric study that participates centers from United States, United Kingdom, and Spain. And it's a multidisciplinary and multicentric clinical trial under the support of a company whose name is Regeneron. So we are treated biallelic autot variants that results from clinically and auditory neuropathy. And as you know, auditory neuropathy from an audiometric point of view is defined by the absence of ABR and the presence of acoustic emissions or microphonic cochlea. So this means that we have this situation in the cochlea with a healthy out cells population, and we have problems at the level of the inner ear cells, especially that impair the neurotransmission mechanism in the bottom of these cells in relation with the first neuron. DV-OTO, that is the name of the clinical trial and the substance that we are using, use 2 adenovirus because we need 2 carriers to put into the cells the gene that is going to restore this mechanism of otoferlin. So we have 2 adenovirus. DV-OTO is split in these 2 adenovirus. They can arrive to the cells, and in the cells there is a fusion of the 2 adenovirus, and we have the complete gene that is going to repair the mechanism. So there are a lot of studies in small animals, in non-human primate animals that demonstrate using ABR that after the treatment of these animals, there are a restoration of the hearing in these animals. So we are speaking about precision gene therapy using a dual AAV vector with selective expression at the level of the hair cells And we use for that a surgical approach that is the same we use in cochlear implantation. So I'm going to describe later on about that. So as I mentioned, it's a clinical network involving major academic centers in 3 countries. And the goal of this clinical trial is to provide durable, high quality and physiological hearing. For that, in the inclusion criteria of this patient, it's very important to pay attention about the absence of ABR and the cause that the hearing loss is related with this OTOF mutation. It's a rare disease, it's not a frequent disease. In our country, it's about 4% of the total of the hearing loss in newborns due to genetic causes. And of course, this clinical trial is approved for the authorities of these 3 countries. This is the design of the clinical trial. So we have a baseline where we apply all the tests we need to select the patients for treatment. We have the perioperative period and the period of the treatment. We use antibiotics before the treatment, and we deliver corticosteroids systemically during 2 weeks after the treatment. And then we have a long follow-up of 5 years where we make different tests to know what is the clinical evolution about safety, audiological evaluation, and quality of life assessment. So we try to analyze the efficacy of the treatment and also that is safe for the patients. From a surgical point of view, we use the same approach we have in cases of cochlear implant surgery. So we make a retroauricular incision, perform a mastectomy, we open the facial recess doing a posterior tympanotomy, we expose the round window, and also we apply a fenestration at the level of the lateral semicircular canal to improve the diffusion of the treatment into the inner ear. We insert a catheter and we start to infuse the DV-OTO treatment that go around the scala tympani, scala vestibule, and the rest of the inner ear. So in this inner ear surgery with intracochlear injection is very important, the round window approach, how we perform the catheter insertion, especially trajectory and length of insertion is crucial, perfusion and round window sealing. So when we are speaking about the approach of the round window, we have to identify the membrane, perform an incision in the inferior part of the round window. Previously, we clean the surgical field from dust power, from bleeding, and etc., and no suction. That's all. The catheter insertion is a catheter of 0.3 millimeters of the diameter. We need to have a very good trajectory, avoiding that the tip of the catheter touch lamina spiralis, basilar membrane, or spiral ligament. So it is important in order to be traumatic during this time, go away from these structures and taking this trajectory during insertion. Know that. The length of insertion is between 3 millimeters and 5 millimeters. So this is also very important. If we insert less, we have back of the DV-OTO to the middle ear. If we go deeper, we have more chances to produce damage into the inner ear. Especially we pay attention, no produce damage at the level of the cochlear aqueduct that is about 2-3 millimeters from the round window level. During the perfusion, we pay attention about the injection volume, speed of injection, perfusion time duration, the application where is applied with the catheter, and also depend the drug that and concentration of the drug that we are using. Also, we need to calibrate the perfusion band for that. And at the end, it's important to have a very good sealing of the round window area. So the round window membrane is able to healing by itself, but we reinforce this area with a draft. So this is a video that shows how is the surgery. This was our first surgery of DV-Auto. So we are, is a child of 1 year old. We are applying the incision. We create a flap, a periosteal flap. We expose the external auditory canal. We initiate the mastectomy. So we are arriving to the antrum, and we are trying to expose the incus, and then to perform the posterior tympanotomy to get the round window niche. In this moment, I am opening the round window niche, drilling some of the edges of this area to have a very nice view of the round window membrane. So we use in that cases a 1 millimeter diamond bar. So now we are preparing the pump for the perfusion. So we apply some covers to have a sterilifying. This is DV-Auto. We connect with the catheter, and we put the DV-Auto treatment in the perfusion machine. I am now checking that the treatment is there. And then when I have this prepared, I continue with another surgical step, that is the fenestration of the lateral semicircular canal. So we are finished the calibration of the pan. Now we are doing the fenestration of the semicircular or lateral semicircular canal. We use a drill of 2 millimeters of diameter. And it's important to keep intact the membranous labyrinthine. Well, now we are ready to make the insertion of the catheter into the scala tympani through the round window. Like some cochlear implants, also is very flexible material. So sometimes, you know, it's no easy to do that. There is a black spot that show you that we have 4 millimeters length insertion, and now we have to wait for 50 minutes to finish the perfusion of the DV-Auto. And during that time, we can check that the fluid came out from the fenestration. When we finish, we remove the catheter, and we proceed to seal the fenestration, and we proceed to seal the round window area. We use for that fascia grab.
Only 3 minutes left.
3
minutes left.
Okay. So we move just to show, right now we have 8 patients treated in total with all the centers. Important to say that we don't observe in terms of safety any adverse effects related with the treatment. And in relation with the results of the first patient that was treated, and we have almost 1 year of follow-up of this, you can see the evolution in terms of results with pure audiometry. This is the baseline, no hearing. This is after 1 month, and in the with 24/8, you see the thresholds that are around 30 decibels. Instead, in the high frequencies, we have a drop in this moment that was in relation with an otitis media in the evolution of these patients. Also, we can observe the evolution of the ABR responses. So this is the mean thresholds with ABR. You see that we move from responses more than 90 decibels, and now we are able to record ABR at the level of 30 decibels. So in parallel, you see the evolution of the mean PTA through the tonal audiometry. So in summary, this is the first human experience with DB-OTO. So from the first 5 patients was treated, we don't observe any adverse effects due to the treatment. And after 48 weeks, we are able to record ABR in a range of 30 decibels. Well related with safety concerns, so no adverse effects. The tolerability of the treatment was very good, and well, we are really happy with the results. Thanks to everybody that is involved in this clinical trial from the different countries, different hospitals. Is a very nice team, and also thanks to the families. So we are working in a clinical trial. This is due to we need for that the cooperation of the families that are participating in this clinical trial. So thank you also very much for the families that contribute for this, and thank you very much.
Thank you, Professor Manrique, for your elaborative presentation. I think now it's time for the break. So, do we have a question here? Just one question.
Thank you, Professor Manrique, for this nice presentation, which opened the future. My question is with the auditory neuropathy. As you know, the auditory neuropathy, when you counsel the patient, you don't know if it is in the presynaptic or postsynaptic. If it's in the presynaptic, it will give good results. In the postsynaptic, we are doubting. So my question is, this gene study can differentiate in a way or another whether this will be a presynaptic or a postsynaptic?
Yeah, by definition, GenoTOF produce a presynaptic problem. No. So this means that this kind of patients is going to have good results with cochlear implants and also with gene therapy. So this open a very important dilemma in terms of to canceling patients because right now we can offer maybe a cochlear implant in 1 ear, gene therapy in the other, maybe both are treated with gene therapy, and if we have a fail in the results, we can rescue through cochlear implants. So there are now opening a new era in the counseling of patients with hearing loss due to gene mutation due to GenoTOF. Yeah, why to open? Because if we inject this DB-OTO treatment without that, we can produce damage into the inner ear structures, and also we need extend for hours the delivery of the DB-OTO treatment. So this means that it's due for safety reasons to reduce injury problems in the inner ear structures, and also to reduce the time of the perfusion of the treatment. Yeah. In the first patient, we use only fascia, and now we are using fascia and bondage to cover that. Yeah. Yes.
One last question, Dr. Nadia.
Thank you very much. It's very nice, and we have heard about these things in the past. Now we see it live. That's very good. But my question about from the genetic point of view, for how long do you think these patients would sustain the improvement you have seen, or do we need to go again and inject the once more, or what do you think?
Well, it's a very, very important question, and we don't have the answer for that. So we know from the animal experiments that the results are durable, but the follow-up of this animal was 3 years. But we don't know. In humans, it will have also a durability in the results of this treatment. Now we are doing research related with the new application and new treatment in case that, results after 3, 4, 5 years go down. It is possible to retreat again. But we expect that only with one injection we have results for life. But we don't know. This is the more an hypothesis.
Animal studies.
Animal studies.
Yes.
So they for sure they keep it for how long with the animal studies?
So the problem is that in animal studies the results are very consistent in terms to maintain the results over 3 years of follow-up. We don't know. We are starting. This is a clinical trial phase 1. So it's phase 1. So it's no. Yeah.
Okay. One last question, please.
Inner ear basically after injection, for example, intracochlear fibrosis, intracochlear ossifications in any patients as a post-operative follow-up?
Yeah, it's a very important issue just to be really traumatic, because otherwise you are introducing a new injuries, and these injuries produce hearing loss. So we try to restore one of the mechanisms that produce hearing loss is due to this otoferlin production. So cochlear surgery, cochlear implant surgery, we learn about how to, introduce 4 millimeters into the cochlea, avoiding injuries. So we must pay attention to be very carefully in this point. And it's true that in the animals we observe a drop of hearing in the very high frequencies. So that this means in human between 16,000 decibel hertz to 8,000 hertz. So maybe we can some damage in this area. But in the conventional frequencies, we have very stable. This means results. So this means that we are not introducing damage in the rest of the cochlea.
Okay, thanks a lot. And because we are late and we have to conclude this session, thank you for your attendance, and thank you, Dr. Manuel.